Sure.
So Dr. Sreeni again is a chief surgeon and medical director of Trust Charitable Eye Hospital at Talaseri, Kannur in Kerala. And as was already alluded to before the webinar, extremely forthcoming, positive, smiling figure, and who has great ambitions for Kerala State Ophthalmic Society and beyond. He's going to be presenting his video.
Yeah, is my video. Good morning, everyone. Thank you, Chitra ma'am, for this wonderful opportunity. We all see these sort of cataracts, hypermature cataract, Morgagnian, a white cataract, and this patient actually came with lens-induced glaucoma, was treated with topical steroids and anti-glaucoma medications, and was taken up for surgery. As soon as you puncture the anterior capsule, you can see all those milky cortex coming out. In these sort of cases, you mostly don't have the risk of this capsule running up to the periphery or the Argentinian flag sign, because though it is really stressed up, it's not once you nick it, the fluid comes out, and it is. See, here you can see that the same, like the capsule. When you do the capsulorhexis, it's very floppy. It is very loose, and you have to be careful while doing capsulorhexis in these cases, because the zonules are also frequently weak in this case. So what I did in this case, and I'll explain why. This was to prolapse the nucleus into the anterior chamber and put the IOL into the back. To create something like an IOL scaffold, which something like the IOL scaffold, which was described first by Dr. Amar Agarwal for managing the nucleus in cases with PCRs. So here, why this was done is because you saw the anterior capsule so loose. See, the posterior capsule is also extremely loose, and you can't, when you do the nucleus manipulations in the back, there is all possibility that you'll catch the PC. And so you have always that in the back of the mind, and you end up doing the surgery in the anterior chamber. Here you have the support of the IOL there, so you try to take the nucleus down to the surface of the IOL. See, the maximum attempt should be to take it as far away from the endothelium as possible. Now it is actually behind the iris and on the surface of the IOL, and do the chopping. See, divide and conquer is out of question. The chopping. See, the chopping here is a bit tricky. It feels funny while doing the chopping procedure. Like it keeps slipping on the anterior surface of the IOL, but the advantage is that you can go as far behind as possible from the endothelium. Make sure that you use a lot of dispersive OVD like Viscod to protect the endothelium. And see, what I do is you chip off a bit from the periphery of the nucleus so that it becomes smaller, and then you do a horizontal sort of a chopping. And that, see, initially you do the chopping, it keeps slipping and all. See, once you eat up a bit of the periphery, then it becomes quite easy. Keep on injecting Viscod to protect the endothelium, and definitely the advantage is that you can go as far away from the endothelium as possible, though you are actually reducing the space available for phacoemulsification because there is an IOL there. So this is it. We can discuss on it, and I welcome you all to AOC 2023 Kochi. It's in Grand Hyatt. Thank you. I take an opportunity to do that everywhere.
Yeah, I sure should, Sreeni. And thanks for a very wonderful topic which you brought forth for discussion. So I would start asking with Dr. Sandeep. Dr. Sandeep Nagvikar, are you there?
Yes,
yeah.
I'm there.
So would you see, of course, he said, I didn't know when I saw the video, he says it was also a phacolytic glaucoma. So do you feel he must have done probably that an injection, a mannitol injection in these cases would decongest the vitreous and make it an easier surgery? Or would you believe that it is only indicated in a phacomorphic glaucoma?
Well, I think I would do that. I would probably, because all these patients who have had lens-induced glaucoma, it's my normal routine to give them about 200 cc of mannitol pre-op, so that you can decongest the vitreous. Even if probably it was not necessary, it's always helpful. You don't want a second element coming into play. I did see a little posterior synechia before he started the capsulotomy. I would have probably released that capsulotomy. Otherwise, Sreeni is such a wonderfully done surgery, and so many pearls to learn from that. This idea of injecting the IOL before doing the phacoemulsification gives you an extra degree of support in these cases of scaffold.
But would you want to place a CTR? Because he kept saying, no, the capsule bag is floppy, which is in a hypermature cataract.
Yes.
Probably the IOL itself with a 3-piece IOL could have stretched the bag. So maybe the role of a CTR is redundant, but I just wanted clarity of the expert. Has Dr. Purendra Bhasin also joined in?
Yes, ma'am, he is there.
Dr. Purendra Bhasin?
So please unmute yourself.
Yeah. Very good morning to everyone. I am sorry for joining late. Definitely, I will go with the pre-op mannitol. Definitely, that gives an edge and some advantage while doing the surgery. And these capsular bags are distended and floppy. So a large sized lens will be better in such cases, and a 3-piece lens is a preferred choice. And I will go for CTR if I find that there is a zonal analysis, maybe preoperative or intraoperative.
Would you, Dr. Shreesh, I would ask you, supposing you are not putting an IOL scaffold in this eye, do you see any sense in doing in the bag chopping? And if you are going to do a chop, it is going to be very slippery, as Dr. Sreeni was telling. Would you have any tip to give on that?
No, this is actually it's a nice surgery, Sreeni, and it's a difficult case, and the floppy bag, and there's no cortex as such to support. There's no cushion effect. And in such cases, ideally, what he has done is the right thing, placing the lens in the bag. And I could have gone ahead with the CTR along with the IOL in the bag, and then gone ahead with the chopping of lens in the anterior chamber. Slightly, that is suprapupillary area, we could have gone ahead and done the chopping. So you just catch hold of one equator of the lens, that is the nucleus, with the high vacuum and high energy, the phaco power, and then you release the power. Once you are inside the nucleus, you release the power, and with the vacuum you hold it. With the help of a horizontal chopper, you go all the way to the opposite the equator, that is 180 degrees away, and bring that chopper, that is the sharp edge of the horizontal chopper, through the substance of the nucleus, that gives a crack. And of course, it's very difficult actually. It can slip away from your phaco probe, but this is how it can be done, and Sreeni has done a good job, and that's how I think. We can go ahead with that.
Anaga, would you think of supposing we were to do it on a laser cataract platform, do you think we would just stop with creating the rexus and not do the fragmentation in this particular case?
Yes, absolutely, ma'am. In these cases, flax
Doesn't work.
nuclear part will not work.
Yeah.
Excellent surgery, Dr. Sreeni. And as we rightly said, in these cases, horizontal chop is what would be preferred, because when you're doing, like you said, initially, even when you are making or trying to get a hold on to the nucleus, having a good hold is important, especially if there is no scaffold. And you can stabilize the nucleus with the left hand, either if you have a dialer or a chopper, and then a sharp horizontal chop. That is the best way, because vertical chop, because there is no support, should be avoided in all these cases. And continuously you should replenish the dispersive viscoelastic combination of sodium hyaluronate and chondroitin sulfate, because if in this case, as you are very anterior, damaging the endothelium, these lenses tend to torque when you are trying to chop. So when you're holding it, if the hold is not good, then it tends to turn and rotate. So becomes a little difficult, but very well done surgery.
Yeah. So the conclusive points are that we do the way the phaco, how we grip the nucleus, and important thing is use a 3-piece IOL as preferably. I think Dr. Sreeni used a single piece because I think he felt that the bag was, the zonules were quite intact, and there is no contradiction to that. And probably one case where we will not use an IOL scaffold is the last question I have. I think we would not use it if it is a dialyzed bag when you feel that the things could be entirely difficult scenario. We would not like to place a 3-piece IOL as a scaffold if primarily when we start. I think that would be the only contraindication, unless you have anything else to add.
I would like to add one. I think pre-op use of steroid would also help in such cases.
Yes, definitely. Pre-op use of steroid. Phacolytic glaucoma, he did add that. And of course, injection mannitol to decongest the vitreous so that you are a very comfortable surgical thing. I think mannitol is even more indicated if it's a phacomorphic glaucoma. So
just one tip, madam, I just wanted to share one of my tips, particularly the nuclei of these cataracts where they are very slippery and they keep on moving. They really do not come into the phacotip. If you make a phacotip bevel down, then definitely you can catch up these nuclei very, very effectively. So that was the only thing I wanted to add. Thank you.
Thank you very much.
I would like to add a point.
Yes. I know I have seen your wonderful video. And I will wonder whether you're one of the first few to start that. Yes, on to your thoughts. Yeah.
We can use the MyLoop or the snare in such cases after scaffolding in order to reduce the...
Don't you think not having a epinucleus cushion at all and the bag could be so, zonules could be weak? I thought a probable loose bag with a weak zonule might be the only contraindication for a MyLoop, unless you are an expert in using MyLoop.
No, after scaffolding the intraocular lens, when the nucleus is in the anterior chamber, using snare or MyLoop will reduce the ultrasound power. The cornea is much safer.
Oh, yes, that's a valid point.